You're fine. No problem. Hi, Dr. Fishman.
All
How are
right,
you?
in the nick of time.
Yeah,
I had a different URL that I kept clicking. I don't know, did it change or what? It doesn't matter. It worked. Thanks for sending it.
not sure, but as long as it worked, we're good.
Yeah,
I just moved you to presenter, so we should be good to go.
good. And remind me what our end time is?
We have until 2 o'clock, so just keep in.
Oh, super.
Yep,
Okay, good. So plenty
that
of time
last.
for discussion. That's great.
And I'll help read any questions from the chat for you as well at the end.
Okie doke. All right. So are you going to give the Max BHIPP intro?
Yep, I'll give a quick spiel about each because we'll have the info going in the chat, and then I'll introduce you, and you can take the floor.
All right, great.
And it looks like we have a few folks starting to join us. We will be getting started right at 12:30. So just in the meantime, please feel free to introduce yourselves in the chat. Please be sure to select everyone in the chat. Sometimes it automatically clicks to host or a certain person. So please be sure to select everyone.
Let me just double check my share. That seems good. And then go into presentation mode. Yep, looks fine.
Perfect.
All right.
All right, it does look like it's 12:30, so we are going to go ahead and get started. I first just want to thank everyone for joining us today. Please take a moment to introduce yourself in the chat. And again, just a reminder to select everyone when using that chat function. You will not be able to unmute yourself throughout this training, so please use the chat function for any questions or concerns. We will be monitoring that throughout, and we'll be feeding some information in there as well. So I'm just going to take a quick moment for those of you who might be new here to introduce who Maryland BHIPP is and who Max is as well. So Maryland BHIPP stands for Behavioral Health Integration in Pediatric Primary Care, and BHIPP supports the efforts of primary care and emergency medicine professionals to assess and manage the mental health needs of patients from infancy through the transition to young adulthood. MAC stands for the Maryland Addiction Consultation Service, and MACS provides support to prescribers in their practices, pharmacists, and healthcare teams in addressing the needs of their patients with substance use disorders and chronic pain management as well. So now I'm going to take a minute and introduce our speaker today. Thank you, Dr. Fishman, for joining us, and thank you again to Max for collaborating with us today for this training. So Mark Fishman is an addiction psychiatrist, the medical director of Maryland Treatment Centers, and a member of the psychiatry faculty of the Johns Hopkins University School of Medicine. Dr. Fishman leads Maryland Treatment Centers, a regional behavioral health care provider, which includes Mountain Manor Treatment Centers in Baltimore and Emmitsburg, as well as several other inpatient outpatient programs. In that role, he's been involved in the development and implementation of innovative programming in addiction and co-occurring disorder treatment. His clinical specialties include treatment of drug-involved and dual diagnosis youth, opioid addiction in adolescents and adults, and addiction with co-occurring psychiatric disorders. His research work is focused on medication treatment for SUDs, as well as models of care and treatment outcomes in youth, in particular, opioid addiction. He has been a president of the Maryland Society of Addiction Medicine and also is currently a member of its board. Thank you again, Dr. Fishman, for presenting for us today. I'm going to go ahead and pass the floor to you.
Terrific. Thank you, everybody. Let me just share my screen, but it's great to be here with you all and appreciate your joining. Just put this on presentation mode. There we go. So we're going to talk today about families. And I'm sure I don't have to tell you, involved in the work with youth, whether it's in pediatric practice or in behavioral health psychiatric practice or school-based health or any number of settings, that families are super important, that they can be a force for good mostly, sometimes for trouble, but mostly for good, but that my message today is going to be that in general we underdo it, that it is hard to involve families, but not as hard as people might think, and that there are barriers, but that those barriers can be overcome and should be overcome. And I'm going to talk about that and some lessons that I've learned over the years or decades, because I'm that old, about trying to involve families and how that can help move treatment along and improve outcomes. So here's an outline of what we'll talk about some barriers, talk about why do it, and then spend most of our time on some of the meat and potatoes, the basics of family engagement, how you address issues of confidentiality, how you address issues of negotiation, what are the positive roles of family, how do you prep them, coach them, that kind of thing. I will talk a bit about some particular examples of family engagement strategies. You may or may not know about one called CRAFT, one called network therapy, and then something that I and my team have been working on for several years for young adults with opioid use disorder, something we called YOURS, the Youth Opioid Recovery Support intervention. And then we'll have, I hope, plenty of time for Q&A discussion. Would love to hear about families or cases that you've worked with, and hear where family engagement, family involvement has been achievable and where it's not been achievable in your practice settings. So let's start by talking about the scope of the problem. Why isn't this done more universally? What are the barriers? And here's some of them. I mean, one is that the young people themselves, and when I talk about youth, I'm talking both about adolescents and young adults. It's less a chronological cutoff, as you guys know, more about a developmental stage and an immaturity, a process of dimensional maturation and developmental vulnerability. But youth themselves will often push back, and that's normative. They have a sense of they want to be grown-ups. I'm all grown up. I don't need my mom and dad to tell me what to do. I've got this. And they think about their parents as being over-intrusive, over-restrictive, up in their grills with telling, within their business where they have no business being. My family just wants to nag at me. Why should I include them? So that's normative. And on the one hand, we want to encourage, we want to encourage the appropriate developmental maturational process of emerging adulthood and the journey towards independence. But as we'll talk about, we know it's not complete. And so this is just something that we have to deal with and engage with. Clinicians themselves, including many of us, certainly when I started doing this work, it's daunting. We're not necessarily specifically trained about family engagement. When you feel out of your depth, you get nervous. It's another set of stakeholders. And whenever you're dealing with young people, you already got a lot of stakeholders. And how do you balance them all? And so there's a sense of not necessarily knowing how to do it, not being comfortable, being anxious. The question of agency, whose side am I on anyway? And learning how to navigate that. The field of SUD, in large part, has focused on the concept of internal transformation, that is, change through internal motivation, wanting to get better. And although there are, as you may imagine, sometimes cases where people have a blinding bolt of lightning from above and an epiphany and the scales fall from their eyes with internal motivation, that's not usually how it goes, certainly not usually how it goes with young people. And so the notion that external leverage, external sources of motivation are also important, and primarily the way that young people come to behavioral change is not because they are initially in action phase, right? When we first meet young people, they are in typically pre-contemplation or pre-contemplation, and that's just what we've got to deal with. You may have heard the term used in SUD jargon, enabling. It's a concept that we sometimes talk about in terms of the dynamic in the dyad between families, parents in particular, and kids, and what has been the course of either permissiveness or a reinforcement of negative behaviors and lack of limit setting and the like. But the problem with that concept is that if that's what families hear all the time, uh, how do you think they receive it? Even if it's true, even if they have been enabling, when they hear that, when their kid's in crisis, when their kid's at risk of dying of an opioid overdose, when their kid's out in the street, when their kid's failing out of school, whatever the consequences are, they hear enabling. And whether we mean to convey that or not, what they hear is, it's your fault. And that's not very helpful, certainly not as an opening. It's not helpful in terms of engaging or welcoming families. It tends to put them off. And part of the problem is to say to families, you need to practice tough love when kids are at risk of dying is a problematic message. And I think that has been historically a barrier. Another barrier has been what I take to be our over-rigid concern with confidentiality. Don't get me wrong, obviously confidentiality is a central linchpin of the work we do in all of behavioral health, including SUD. But it's very easy for us to get legalistic and say, HIPAA won't allow me. That's against the rules. I can't talk to you. I can't tell you how many times families have told me they've knocked on the door of trying to be involved in treatment and, get the cold shoulder. Just to make a cartoon out of it, little Johnny's living at home. Mom and dad are paying for the treatment. They bring the kid to treatment. They're waiting in the lobby. They know the kid's in there. They've admitted them to the clinic. And then they call the counselors, say, can you tell me how Johnny's doing? And what they get the kind of old saw. We can neither affirm nor deny that a person by that name is receiving treatment at this facility. Please contact our legal department between the hours of blah, blah. And I'm exaggerating a little bit, but maybe not by much. And so, as you'll hear me say, I think that we can navigate these issues without getting too hung up on the what I take to be over-rigid concerns, and that we can both respect confidentiality, but have the default expectation that we're going to figure out ways to communicate. And it's about how you do it and how you finesse transparency, disclosure, and communication, but that it can be done and ought to be done. And then lastly, just that SUD treatment in general carries a whole host, and behavioral health treatment across the board carries a whole host of stigmatizing issues in which family involvement is sometimes seen as shameful. And, on the one hand, if you think of any other subspecialty in clinical medical treatment, it's natural to involve families. If grandma has trouble taking her pills, you help her out. If your loved one isn't understanding the instructions of the highly technical consultation that they're receiving from the specialist physician, you go to the appointment with them and ask questions and take notes and call them up. But we don't do that in behavioral health, and we certainly don't do it in SUD because it's a secret, because it's shameful, because we don't know what the role of family ought to be, and I think we can do better. So anyway, there's a list of some of the barriers. Other problems include some of the perspectives that you might imagine various stakeholders have, and I'm going to cartoon a little bit from the point of view now of families, the point of view of patients, and the point of view of staff. Again, over dramatizing it a little bit, but just so you'll be familiar, I think, with some of these perspectives. Patients will say of families, well, they don't understand me. This is my treatment. It's none of their business. They just get crazy, angry, critical, punitive. They just assume I'm guilty. I get no trust. I'm automatically assumed to have to be lying. I don't want to be treated like a child. I'm not a baby. I'm a grown up. We've talked about that. And you can't talk to my family. I know my rights, and I'm a lawyer up on your bleep. Yeah, again, that's extreme, but you sometimes hear these gradations of resistance from patients. And from families, they get the sense that I'm boxed out of my loved one's treatment and have no input. I can't even get any info. Back to this enabling idea, treatment professionals tell me I have to let go, use tough love, respect boundaries, stop rescuing them. But what do you mean stop rescuing them? If they're going to die, if they call me from midnight from the park where they have no place to stay out of the cold, of course I'm going to rescue them, as any parent might say. And so these are difficult things. That, by the way, there's other families who I'm done, and you can't get them involved. It's not that they're knocking on the door and that we're refusing them. It's that you try and you can't even reach them, and they're up to their ears in alligators and said, I've done everything, and you can't even get them on the phone. And then counselors, the patient is being sneaky and devious in not letting me talk to the family. The family is being overbearing and ineffective. And besides, confidentiality regulations tie my hands. So, just various perspectives, again, on barriers and why it's difficult. So with those barriers in mind, let me make the case for why it's so important. And hopefully this will resonate with you. And for many of you, this is obvious, but I think it's important to go over it again to make the case that it can be very powerful. Let me use a vignette to illustrate some of this. So say we've got a 17-year-old young man, he's a high school student living with his parents. He's smoking a whole lot of cannabis. He's escalating his binge alcohol use. He's just recently taken some opioids, say at a party or from some friends, and seems to like it. So who knows, that could progress. Not yet at the level of daily use or physiological dependence or full disorder, but we're certainly worried. And his view, right, is, there's nothing wrong with weed. They treat me like a child. They're always screaming at me. I'd just as soon live on the streets. Woe is me. And their view is, if he doesn't get it, if he continues to do these things, he'll never get anywhere. He's acting like a shiftless bum. He lies and he steals. We can't get anywhere with him. And you try to say, well, let's begin a process of discussion and negotiation. And you try to broker, as again, I'm going to advocate is the appropriate thing to do. Parents, you can set some rewards and consequences for behavior to the patient. You can have input into setting these goals for rewards. Let's work on communication skills. But despite your best intentions, parent, we don't have time for this. You say we should stop driving him if he won't do X, Y, Z, but we can't stop driving him because then he wouldn't go to school. You say maybe we should set limits by taking away his phone. But we can't do that because then we won't know where he is. And besides, he threatens he's going to run away. And so the whole thing will go to hell in a handbasket. What's the point? He doesn't listen. We're not getting anywhere. Your methods are useless, you stupid doctor. We'll just throw him out of the house. So, there's this quick escalation to the nuclear option. And on the other hand, the patient says, I don't want to meet with them. They don't need to know my business. Your idea that they'll give me rewards is nonsense. They'll never give me rewards unless I'm perfect, and I'll never be perfect. What's the point? And they threaten to throw me out, and so I'll just live on the streets anyway. Again, I'm exaggerating to make the point, but you can see that whereas you have good intentions, whereas we want to make this happen, it's hard to do. One of the questions is there a balance? For parents who have kids that have progressed through SUD, and most of the kids with SUD, also have co-occurring other vulnerabilities, including a variety of psychiatric disorders, mental health conditions, disadvantage, whatever the other mounting problems are. And so they present to you, they're up to their ears in alligators. They have said they've tried everything. I'm not saying they really have tried everything, but that, they tend to have said that. This is not their first rodeo. And so they're skeptical, and they tend to polarize, if you will, between these two cartooned extremes. On the one hand, it's got to change. I can't take it anymore. I've been trying everything. I've spent time on treatment and rehab and lawyers and replaced the car he crashed. And I don't have tolerance for this. And they will be in catastrophe mode. The only button they have is the nuclear option button. And if they can't be perfect, I'm kicking them out of the house today. Versus helpless mode. Again, I've tried everything, but it doesn't matter what I do. My child is going to use or continue to be depressed or be suicidal or both or whatever it is, misbehave, get in trouble with the law. There's nothing I can do. There's no point even trying anymore because I've tried everything. And then they get to this passive, don't ask, don't tell. I don't want to catch you using because I wouldn't know what to do about it anyway. So I just don't want to know about it. And neither of these polar extremes are particularly effective, as you can imagine. So our job in trying to learn how to engage families and productively involve them in treatment is to find some middle ground and to move them away from seesawing here between these ineffective polar opposite strategies to some consistency in the middle, less catastrophizing, more engagement, but engagement in a productive way. So to summarize, some of this rationale, both families and patients need a recipe for treatment with role definitions, expectations, and responsibilities. So that is on us. And it's often all too easy to just expect that everybody will know what to do. But, families, both patients and the parents, they don't know what we know. They don't have the experience. It's all new to them. They tend to be skeptical. They don't know the secret handshake and what happens in treatment. So you need an explicit kind of role induction, and you need an explicit recipe for what your job is and what you're going to do and what the rules of the road are and how this is going to go and what my role as the conductor of the orchestra or the broker of the communication is going to be like. And when people are given assignments and roles, they can be more successful. They won't always follow your instructions. In fact, they often won't, right? But at least if you kind of are explicit about this is what usually works. Have you tried this? This is your job. This is your job. And at their core, families have a kind of competence that is based on the family role, the role of caretaker for young people, the kid, whether that kid is 15 or 25, or maybe even 45, I don't know. But the notion that they're in it for good, they have deep connections and love and caring and special powers of persuasion and natural leverage that we can never have. I mean, we have other assets, right? Our professionalism, our expertise, all of that, but we don't have the longstanding relationships. We don't have the parental caretaker role, and they'll be there long after we're gone in the life of this particular young person. And so it's important to start with the view of respect and acknowledgement that the families have a whole lot to offer. They may need sprucing up. They may need some coaching. They almost always need coaching. They may need some feedback about how to tweak what they're doing. But and certainly there are some families that are so toxic and so dangerous, that we end up trying to separate patients from the families. But that's the rare exception, when families are putting the kids in imminent danger. But for the most part, families have a lot to offer. And so part of what we need to do is learn how to enhance and harness that core competence. And certainly we have medications, whether they are psychiatric medications or anti-relapse medicines for SUD. And that's all well and good, and certainly they are core and standard of care. And I'm going to talk more about how medication treatment can be an important element, sometimes the lead element in developing a family engagement strategy. But it's certainly not going to be where things end. And, families will often, grasping for straws as any of us might, want to think, oh, thank God, the medicine, the antidepressant, the buprenorphine, the whatever, finally we've got a cure and now we're done. And of course, you and I know that that's not true. And none of our medicines are curative. Even if they have high effect sizes, they aren't enough. And you still got to parent this difficult young person. And you still got to go the distance. So let's spend some time on that. One of the things that it's important to remind both families and patients about, at least in my view, is that involving families is not contradictory with endorsing, encouraging, and advocating for emerging patient autonomy. I mean, the key is it's emerging. These are patients who've got 1 foot in childhood and 1 foot in adulthood, but they're tweeners, right? And as they're learning how to exercise appropriate autonomy, they can also benefit and utilize the help and support of adults, especially their adult caretakers. And you can both empower families and encourage emerging autonomy. They are not incompatible. That's a double negative. They are compatible. And I think that you can teach both patients and families how that both goals are mutually reinforcing. Now, sometimes that's an uphill teaching exercise, but I think that most people are receptive to it if you handle it right. Now, the devil's in the details about how you handle it. So how do you handle it? Well, let's talk about how some of those basics can go. The first thing is, I think, thinking about confidentiality issues. These might be easier with younger adolescents, where the expectations are of, families' involvement in most treatment decisions. But even then, it can be a sticky wicket. And the older they are, as they get towards older adolescence and into young adulthood, the more it is important to be very explicit about this. That is, what are your concerns? How are we going to manage this? Who's allowed to communicate with who? What are the rules of the road? And we want to avoid the trap for us as clinicians of these polar opposites. On the one hand, are we going to follow rigid limitations on disclosure and communication? Or are we going to ignore issues of confidentiality and willy-nilly make unilateral and surreptitious disclosures in one or the other or both directions? I think, as you can imagine, the answer is, of course, neither of those. The answer is we want explicit consent. We want acknowledgement of a need for collaboration between the parties of the patient and the family. And if you haven't done this work, you might be surprised that most people will agree. You'll get some pushback. Oh, no, I can't include them. And it's not necessarily an emergency to do it today, but the key is getting to yes. And my experience is you can almost always get to yes. I mean, I've had a handful of both families and younger patients who have been diehard holdouts, no way, no how. But I got to tell you, that is rare. And early on in doing this work, I was surprised. But it turns out if you are patient and if you work at it and if you show some compassion, and we'll talk about meeting with people together and individually and setting an agenda, you can get to yes. And you don't have to do it usually on day one. I mean, obviously, in cases of imminent danger, suicidality, high risk of imminent fatal overdose. Okay, but those are unusual. It doesn't have to be today. And you're going to work on how do we get to assent, consent, agreement, a framework for collaboration, and doing that from the beginning puts you in good stead. Here are some potential approaches to family communication when you get pushback. You shouldn't be surprised that you get pushback. My point was not that people will always say yes in their first breath. Expect pushback, expect skepticism, expect reluctance, expect, what are you up to? You're just going to rat on me, right, with my parents and get me in trouble. So when the patient says, you can't talk to my family, are you going to say, okay, never mind, we won't include your family? Or are you going to say, oh yeah, watch me? That's the other polar opposite, right? The two polar opposites are not going to do it just because you say no, or going to do it anyway, no matter what you say behind your back and surreptitiously. Or should I say something like, well, all right, I understand you may not be incredibly enthusiastic and eager about me blabbing to your family. I get that, but they're going to call me. So what do you want me to tell them? So drawing them into a collaborative kind of mode. And as you guys know who work with young people, it's very engaging to get them to be the instructor in the room. Teach me how you'd like me to do it. Give me some suggestions. Doesn't mean you have to follow the suggestions, right? But it engages them. What do you want me to say when they call? What are the pros and cons of a particular approach? Or should I say, you can't talk to my family? Well, fine. I'm not intending to sneak behind your back, but let's talk to them together. So trying to collaborate and set the ground rules and show an example. And in doing that, you can begin to engage both parties. Part of getting to yes is to normalize these conversations. Make it standard. Not everybody's practice makes this a standard, and it is time consuming and it's hard to do in 7.5-minute office visits. But if you can squeeze it in, normalizing it. Why would you want to talk to my parents? Well, it's what we do. It's standard. Of course I do that. They care about you. They love you. They brought you here. They may have something to contribute. I'm not saying I'm going to tell them everything, and we're going to talk about negotiating that, but that's what we do. Just give it a try. You can always fire me. Let's invite them in and see what happens. What's the worst that can happen? Don't you want their help? You tell me that all they ever do is criticize you and they never help you. Give me a chance. What if I could help you to get them back off And here's a great engagement trick. If you can demonstrate in front of a young person with the family in the room that you can set limits on the parents if they are in fact being over intrusive, over punitive, screechy, screamy, unreasonable, critical. Excuse me, Mrs. Jones, just for a minute, maybe tone it down a bit. Let's let him have something to say. Maybe you could say that. Whatever you can do, you got to figure out your own style. What's the diplomatic way to show that? But if you can earn points for being able to stand up to mom or dad because of the professional mantle of your authority, that's big engagement momentum. And vice versa, setting limits on the young person in front of the parents. Hey, maybe you shouldn't talk to your mom like that. That's not going to get you the trust that you want. That models more productive ways of giving the message that they may have given in a screechy, screamy kind of way when you're not in the room. So again, modeling behavior, asking for permission to be an advocate, demonstrating that you can be an advocate, demonstrating that by being a communication broker, you can add something that they couldn't get on their own. Another thing you can say is, well, I know you don't want your parents to know XYZ, that you haven't stopped smoking, that you're selling cannabis, that you've tried opiates, that you failed that test, or I don't know, whatever it is. But you know what? The truth will somehow come out. It's hard to keep the lies untangled. They're going to find out anyway. And that usually resonates with people. They're going to find out anyway. And wouldn't it be better if you get points for honesty and a commitment to communication, and if it comes from you, rather than they bust you for it later, and then that just escalates the drama, which is exactly what you're complaining about. And you know how they're going to respond, right? If you're worried that that's what they did last week, it'll be worse next week. So what about doing it a different way? By the way, that doing it a different way line can be very helpful. I use the expression, people say, why should I do that? And you say, well, what you're doing now, how's that working for you? That phrase, how's that working for you? You don't want to do it sarcastically or in a way that is implicitly criticizing. But if you can do it in a way that gets people to say, or be willing to go with you to try something new just because what they've been doing isn't working, that's often very helpful. Now, families are not necessarily intuitively good at this. In fact, by the time, if they're the families that are taking care of the patients that you and I are taking care of, they're there because they're not good at it in large part. So you got to spend some time with the families, teaching them about the principles of negotiation. And this will largely be news to them. As I'm going to say, part of the strategy to get here is meeting with families alone sometimes without the kids, to give them some coaching, some training, some advice about how to do this. You can also do it to some extent with the kid in the room. But either way, understand that while you're recognizing the inherent core competence of families, you're also trying to move the needle on their skills, and they will usually need quite a lot of help with this. Some of those principles are as listed here. You know, they've got to pick their battles. It's so hard for these families who are living crisis to crisis. They lose perspective, don't they, right? What's the important goal? Why can't I ask for this and this and this and this and this? All the other kids do that. My other kids do it. The neighbor's kids do this. He used to get A's. He used to go to soccer practice, et cetera, et cetera. Well, because how's it working for you? It's not working. All you're doing is battling. You can only have one or two, maybe at most three things, but three is usually more. And you got to prioritize. And you got to decide where are you going to invest your efforts. You're used to this in working with little kids, right? With families of little kids, right? If they're going to go chase the kid after a disciplinary interaction because the kid sasses back or rolls their eyes, it only escalates. So teaching parents to hold back and don't worry about the eye rolls, stick to the message. Just as an illustration of this, as you probably know, I spent a lot of time working with really deep end kids who have both SUD and co-occurring disorders, and say many of them are injection fentanyl users at risk of lots of high-risk consequences, including fatal overdose. And I can't tell you how many times get into the conversations with the families, and they want to know why I can't get little Johnny to clean his room. Or they want to complain about the new girlfriend or the new boyfriend or the latest tattoo. And wait, we gonna talk about injection fentanyl, or are we gonna talk about how messy the dresser is? You pick, but you can't have both. You decide. But my advice, just saying, is let you know, etc. So, but it's easy to understand why people lose perspective. Again, I keep saying they're up to their ears in alligators. It's hard for them to tell. So you got to keep coming back to that. You got to keep coming back to teaching them about leverage. They tend to get overwhelmed and hopeless and frustrated, and they forget that they usually have more juice than they know. That's important for us too. You know, families have a lot of juice, but they don't know it. They don't know how to use it. And they will say things like, well, I'm not made of money and I can't pay him for being good. And I can't take him out to the movies every night just because he didn't, insult his mother and beat up his sister. Well, okay, that's not what we're saying. We're saying is be consistent. Do it the way you do it in your family. I'm not saying what's right and what's wrong. I'll give you some input, but your family has a particular style. But develop that in a consistent way, not in a reactive, punitive, inconsistent, catastrophic way. And whatever you're doing for this young person, and every family's doing something, is it nice meals? Is it family time together? Is it pocket change or an allowance? Is it allowing them to use the car? Is it driving them to someplace? Is it taking them out to the movies? Is it privileges and rewards? Whatever it is, whatever your family is doing already, now in a more systematic way, try to link that to treatment goals. Try to link that to positive behaviors. And again, you got to be selective. You can't have them all. You got to pick one or two or maybe three, but three is usually too many. And keep your eye on the prize, because this is going to be a marathon, not a sprint. I wish I were able to offer you a cure. I'm good, but I'm not that good. And so you got to see the big picture and not sweat the little stuff. There's going to be lapses and relapses. Of course, I'm not advocating or wanting that, but big picture, keep going. And you're going to have to give to get in some kind of negotiation. Well, why should I have to give anything? Why should I have to bribe him to be good? He's supposed to do that on his own. Wow. Again, how's that working for you? The reason you got to do it is because that's what works. And because you want this young person to engage with you. Part of what you complain about is they'll never talk to you, that they keep secrets, that they're off in their room or out of the house or not coming back at night. So you got to engage them. They got to see some investment from you in process, even an exaggerated investment in process in which you're making a big fuss about empowering them. I'm not saying you have to give in to their crazy whims. Why won't you let me use heroin in the living room? No, I'm not saying that that's what you have to give, but you got to give some. Rewards will always work better. I'm not saying the consequences are worthless, but a reward, 10 rewards for every consequence. And to the patient, why should I have to do everything they say? They never give me any credit. Well, if you can figure out a way to earn mom points and earn dad points, it will be worth your while because you'll get good stuff. And so we have to learn together what the appropriate currency in your family, with your mom and what your dad and your dad, what the appropriate currency is, and how you're going to earn trust back, and how are you going to get the things you want. And in part, it's going to be because I'm going to help you help them understand what the important things are. But also, you may have to give in a little bit to their idiosyncratic goals and peculiarities that you don't agree with, in order to get the bigger things that you want from them. And again, aren't you tired of battling, and how's that working for you, as I said before? So how do we build alliances with families? How do we make them partners? And it takes investment, and it takes time, and it takes work. Part of it is meeting with both the young person and the family members separately and together, alternately. And part of the separately is to work on psychoeducation, because you got to explore their knowledge and goals, and you won't be shocked to hear that they usually don't know a bunch of stuff. What does your dad know about your substance use? What does your mom know about the medications for depression or for opioid use disorder? What is it you think about your son's cannabis use? Super important, right? Because in this current culture in which cannabis and other intoxicants are no big deal, not really a drug, we did it when we were young, why are you making such a big fuss? It's really important to know where the families stand. And if you want them to be in alliance with you about behavior change, you got to explore what they think, because if they disagree with you, they'll be undermining you. And so it takes some education. And hopefully they will be more amenable to reason and understanding the science behind the biology of substances or of psychiatric illness than the young people. Well, not always, and the culture is against us at the moment. The culture is pretty pre-contemplative, but we try our best. So, and the same thing with the young person, meeting separately, teaching them how to work their parents, allying with them each, so that when they're together, they both see how you're working both sides of the aisle. It's an art of the deal, really. You're advising the families about strategies, and that's delicate because they will feel criticized that you're calling them bad parents, and you're wanting them to improve in their parenting skills. So you're coaching them, but you want to do it in a sugar-coated way that empowers them rather than makes them feel beat up. And one of the things that you can say to families, again, they have more juice than they know. Kids living in your house, you're providing all this stuff, you're supporting this young person. You can insert yourself into treatment more than you may have known in the past. Now, not every provider will do this with you, but you should assert yourself. You can negotiate for, you can insist on ROIs for communication. You want to know about test results, in particular when I'm talking about SUD, I'm mostly talking about urine drug tests. That can be part of what you insist on. You can insist on joint meetings. Again, you got to pick your battles. You got to think in advance about what your leverage points are. But it's perfectly appropriate for you to say, if I'm supporting you, if I'm supporting this treatment, then I need to be included in it. And part of the negotiation in thinking about the communication rules of the road is making it explicit. Mom, Dad, I'm not going to tell you all the gory details. You're going to have to trust me. Sometimes I'm going to keep some secrets, but I promise you, I'll tell you what you need to know. You'll get the big picture. And to the young person, what is off limits? What am I allowed to talk about? What are the things you'd rather they not know? On the other hand, I want you to hear that if I'm worried about you, if I feel like I have to push the panic button or call the cavalry, I'm going to do that. I'll never do it without your permission. I'll never do it without behind your back. I'll always try to include you in doing it, but I want you to hear that it's vital that we get you help when you need it. How can we make this go? How can we practice, et cetera, et cetera. So those are some of the basics. and I want to now tell you about 3 particular interventions that incorporate some of these principles, just so you get a sense of where the state of clinical practice and research has been. By the way, this will not work, right? This is back to the parents' kind of punitive, why do I have to do it? You have to do it because I'm the mom, I'm the dad, it's my way or the highway, and Gandalf with the Balrog usually doesn't work. So CRAFT stands for Community Reinforcement Approach and Family Training. Was developed by a colleague, Bob Myers at the University of New Mexico. And this was an approach in its original conception to help families who had a loved one with a substance use problem that was not interested or yet motivated for treatment. His first work was explicitly with the wives of alcoholic husbands. And that was the target population. There's since been, both by him and by other people, expansion of the target population and replication to other substances besides alcohol, to other pairs of family, not just wives and husbands, but partners and parents and children, and any number of family involvement. And the goals were to work with the concerned significant other. The jargon is CSO, concerned significant other. Sometimes you'll see the jargon TSO, treatment significant other. And your loved one, your husband, your partner, your wife, your kid, your cousin, your adult parent, whatever it is, your loved one has a problem. Loved one does not seem especially motivated for treatment. It's increasingly frustrating to put up with this. I can't seem to do anything. I can't get the horse to water. Well, let me work with you as the concerned other, even without the loved one showing up, even without the designated person showing up, the designated patient showing up. How can I coach you? And the goals explicitly in this CRAFT treatment were to move the loved one towards treatment, reduce the loved one's substance use as best you can, even prior to engagement in treatment, and have the CSO focus a little bit on their well-being so that they can sustain their energies without being demoralized and quitting. Got to take care of yourself a little bit. And some of the methods included what we've been talking about, teaching about communication skills, stop nagging, be positive, be brief, refer to specific behaviors, use I statements, offer to help. I mean, these are the standard tricks of the trade that you guys know about from CBT skills rehearsals for communication skills. And it's not, you're not going to get mileage by saying that I'm tired of you being an alcoholic. I'm tired of you having an addiction. You've got to say this particular thing was problematic. I would prefer if you do this other particular thing. And I want to be positive about last Tuesday when you did a really good thing. I feel hurt, insulted, left out, rather than you are a no good son of a blank. And teaching the basic methods of operant conditioning. How do you shape behaviors? Standard stuff. Be consistent. Use healthy, natural rewards. Bob's a bit of a salty guy, if you've ever heard him talk. And as he started this, one of the things that he would say to these women is, listen, tell them that, of course, you're not interested in kissing them when they stink of liquor. But I'm much more likely to want to kiss you when you're sober. Again, just an example of a healthy, natural reward. So that's CRAFT. And by the way, I'm going to come back to this if we have time. We are now trying to use these principles of CRAFT family training as a way of approaching families of young people. We have a new project here, which I'll tell you about if we have time, in which we're encouraging families of adolescents and young adults to come forward, even if the adolescent young adult is not interested in treatment. How can we just work with the parent alone towards the eventual goal of getting them into treatment through some family coaching. Another historical approach to family engagement in SUD treatment was developed by Mark Gallanter at NYU in New York City. He's a leading luminary in the field and an all-around great guy. And his idea was for people in treatment. So whereas Kraft was pre-treatment, working with families where patients weren't yet patients, hadn't come into treatment at all. Patients who come into treatment, how can we involve your partner? Again, starting with husbands and wives, but now expanding to parents, kids, romantic partners, cousins, whatever. How can we use your significant other, your CSO, your TSO as a treatment partner? And in particular, his big innovation was to use the CSO role to monitor treatment participation and in particular monitor medication adherence. He first started doing this with disulfiram, antabuse for alcohol use disorder. And you guys may know disulfiram is a highly efficacious medicine in the lab, but very low effectiveness in standard community practice because adherence is low. Most people won't take it. They'll just stop it and then resume drinking. So in general, we think that disulfiram is appropriate only, you just can't just write a prescription and say, here's 30-day supply, good luck, have a nice life. You've got to add particular specific adherence enhancements. And that was Gallanter's kind of big innovation, was to say, we're going to use the TSO to create the structure and fabric of this adherence enhancement by being the medication monitor. So every morning, you're going to take the medicine in front of your partner. And that person can help encourage your adherence, can monitor it, can praise it, can remind you, can report to me, the physician, if it doesn't go well. You got to train them not to nag. You don't want to escalate further conflict. That's not helpful. But tell me if he's not taking it. Let me be the bad guy. And you're the monitor to help us know whether adherence is happening. And then Dr. Gallanter also extended this work more recently with daily sublingual buprenorphine adherence for opioid use disorder, and has had some very nice research results here. And so that's the basis of network therapy. Again, just another way of using some of these principles. And then I wanted to talk briefly, how are we doing for time? I wanted to talk briefly about a thing we've been working on, the Youth Opioid Recovery Support Intervention, or YORS. And the rationale is that, not surprisingly, young adults don't do as well as older adults in OUD treatment. Now, again, these are deep end kids. You may not be the ones that you guys are seeing in primary care and in basic behavioral health treatment. You may be seeing more early stage cannabis and alcohol and nicotine users, but we have these great medicines that you probably know about, MOUD or MAT, and they are the standard of care, buprenorphine, methadone, extended release naltrexone, and they work in young adults, but they don't work as well. And this is just one bit of research we did to illustrate the point. This is a secondary analysis of a famous seminal trial in SUD. It was called the XBOT study. It was a randomized trial of extended release naltrexone versus daily sublingual buprenorphine with a 6-month course. And the main results of that trial, which you may or may not know, is that it's easier to get onto buprenorphine than extended release naltrexone. So in an intent to treat analysis, you get lower relapse rates with buprenorphine by a small margin, because some people just never make it onto naltrexone because it's a little harder to do. But if you do a as taken or a per protocol analysis, just looking at those that get onto medicine, the two medicines are equivalent once you're taking them. But this secondary analysis was not comparing the different medication arms. It was comparing The young adults in the trial, there were about 100 of the 450 total participants versus the older adults with both medicines pooled, and looking at the 6-month relapse rates. And you can see here the substantial difference that whereas 49% of the older adults were non-relapsers at the end of 6 months, only 34% of the younger adults were non-relapsers at the end of 6 months. Now, 34% is far better than we would get without medicines, don't get me wrong. Still the standard of care, still a very valuable and life-saving treatment, but we have much room for improvement, because of the developmental vulnerabilities of young people. So this yours intervention is intended to try to intervene with young adults with a variety of multimodal components. It includes assertive outreach, includes home delivery of injectable medications. It includes giving them incentives for receipt of medication doses. But since we've been talking about family today, I want to focus on that. It includes a large component of involving families. And part of the deal is that every young adult in the intervention designates a treatment significant other, typically a parent, but it could be a cousin, boyfriend, girlfriend, whatever. You can imagine that they're young, that the young adult romantic partners are somewhat transient and generally don't work out as well as the parents. But whatever they pick will work as long as they're not actively using drugs with them. And some of the elements of these family sessions are illustrative of the principles of family engagement that I've been talking about. Working to educate the families about opioid use disorder, which they usually don't know a lot about the medications and about other aspects of treatment. Working explicitly to get a collaborative treatment agreement between the youth and the family members. And that includes, what's the schedule of treatment going to be? How are you going to get here? What medicine are you going to be on? Who's going to communicate what? Who's allowed to know what? And, we write it down and sign it. Not that it's a legally binding document, but at least it's a ritualistic memorial of what everybody's kind of agreed to that we can come back to later when things maybe aren't going as well and say, well, wait a minute, when we met last time, you said that, see, look here on page 3, where a lot of emphasis on the same kind of skill building and communication that we talked about. Explicit role for the family to give them assignments. How are you going to support this treatment? What is it you're going to track? Are you down to the nitty-gritty details of transportation and monitoring of the dosing, and how do we contact you if they miss a dose, and that kind of stuff. And perhaps most importantly, what's the backup plan, or the backup to the backup plan, or the backup to the backup to the backup plan? How are we going to rescue you if, God forbid, things don't go well? Oh, don't worry, I'm really committed. I really mean it this time. No, that's great, but just in case. Mrs. Smith, if it doesn't go well, how do you want to manage this in your family? Johnny, how would you like your mom to help you if you miss a dose, if you have a lapse, if you have a positive urine, if you start smoking cannabis again, what are we going to do? How's that going to work in your family? And let's write it down. And here's just an example of a particularly good outcome. Got a 23-year-old young man who's injection fentanyl. He's got several inpatient detox admissions over the last couple of years, and several times gets a first dose of extended release naltrexone, brand name Vivitrol. You may know about it as an opioid use disorder medication. By the way, we're also using extended release buprenorphine, brand name Sublocade. So it doesn't matter which medicine, they're both equally effective. Pick one, but be on a medicine. And how can we improve adherence? But this person's gotten a dose before, but then after rehab never comes back, never comes to outpatient treatment, never gets a second dose, relapses every time, revolving door, back in detox 6 months later. So this time he enrolls in this youth opioid recovery support intervention. The Yours team is working with them. And grandma is the primary parental caretaker, lives with grandma, and he's gotten a first shot, and now it's a month later and it's time for a second shot. And so the team goes out to the house, because remember I said home delivery is part of it, which can help reduce barriers for some people. Some people come to clinic, but some people won't. And you go to their house, knock, knock, ding dong, medicine calling, injectable naltrexone calling. By the way, similar to what you guys may know from assertive community treatment, home delivery of long-acting injectable antipsychotics for schizophrenia, right? Borrowing from that playbook. Anyway, here we are, and as before, past behavior predict future behavior. Patient says, no, thank you. I'm good. I don't want your stinking shot. And I don't know whether that's because he's already relapsed or he's planning on relapsing tomorrow or next week and doesn't want the shot because of that, or whether he doesn't want the shot because he's invincible and he's committed, but he doesn't want to be weak and doesn't think he needs the medicine. I can't tell the difference, but either way, he says, no, thank you. But now, which he's done before, right? But now grandma is involved and grandma says, no, no is not an option. You got to get the shot. You're living in my house. I'm involved for the first time, and she's empowered in a way she hasn't been before because she hasn't been included. Now I'm involved. You get the shot. And she's got leverage. She's got juice that I don't have, that the therapist doesn't have, that the home delivery nurse doesn't have, right? She can lay down the law because of her relationship, her love, her connection, her authority, her persuasion, all of those things. And it's a done deal. He gets the shot. And in fact, he's the poster child. He gets 6 doses over the 6-month intervention and does well. Now, obviously, not everybody does that well. Plenty of people don't listen to their grandmother or don't have this effective of a grandmother. But anyway, this is the idea. Another thing that we do for communication is 3-way texting. So it's a way of having open, transparent communication. Obviously, we're the beneficiaries of the largesse of a NIDA federal research grant. So, we can have small caseloads and people have lots of time. This is hard to pull off, right, without the resources and standard care with big caseloads. So I'm just kind of giving you a flavor of what we're developing in boutique research. But anyway, we've got this group texting, and it's a nice way of, you got the parent on the text, you got the patient on the text, you got the therapist on the text, and people can be open, and monitoring is one way of doing it. Just want to let you know that Brittany got her shot. Great, thank you very much. Hey, Dave's the dad. Although the kid had been late, had missed some shots, he's back on the shot. Just want to let you know. Oh, that's great news. Thank you. Here's an example of what I think of as a potential empowering strategy for a parent. Not saying it's the right move for the parent. You'll see as soon as I describe it. And I think that there's pros and cons, but I think it's illustrative of the natural kind of leverage that a parent can have that I can't have. So the team goes to deliver a shot, and you look in the home for a private place where you can kind of administer the injection. And naltrexone, by the way, is a gluteal injection, so you especially want to have a little privacy when the patient drops her drawers. And mom's tagging along, following the team and hovering over. And the patient, naturally enough, says, Mom, you can't be in here while I'm getting the shot. And the therapist says, or the nurse says, ma'am, I think it's best if we provide her privacy. After all, this is supposed to be a confidential, health procedure. And the mom says, are you kidding me? No way. I'm not leaving this room till I see that medicine go in you. Now, maybe she's being over-intrusive, maybe she's being over-dramatic, maybe she's crossing the line. But I think it's a nice illustration of a mom wanting to step up to be part of the solution. Now, hopefully going forward, we can get her to stand down and not be quite so intrusive and be able to trust the team. Don't worry, ma'am, we saw it go into her. We're not going to lie to you. But again, part of a process of getting people to be more effective. And you can see that in this intervention, I'm not saying it's the only way to go, we've chosen medication as the thin edge of the wedge or the tip of the spear, right? That is, there's lots of other things that are important in terms of recovery, rehabilitation, resumption of and restitution of psychosocial function, but the medicines are a good starting place. And that's for a number of reasons. One, because they're concrete. and easier to understand. Like, right, an injectable medicine, it's a verifiable, deliverable event. It went into them or not. It also, these medicines happen to have very high effect size in OUD. Unfortunately, we don't have that for cannabis use disorder. We don't have that for cocaine use disorder, right? So, but for OUD, we've got high effect size medications. And so it allows us to be medication forward. And then the other thing that I think is that medications are easier for people to get their heads around in terms of thinking about utilization of the healthcare system. They may not be the most important things, but they're easier to understand than therapy, than CBT, than group, which is all a little mysterious. But everybody understands, at least in the American healthcare utilization, what it is to go to a doctor and get a medicine. And it's very familiar territory for parents, especially moms, right? Because everybody has had the experience of a 5-year-old with an ear infection and a fever who didn't want to take the pink medicine, right? And you had to hold them in a basket, hold and squirt them in it. And moms are used to the idea of a truculent, irritable, sick kid who's not in their right mind and doesn't have the maturity and capacity to get appropriate health care. Now you got to take that 5-year-old who you can hold in a basket hold and translate that now to a 19-year-old who weighs 250 pounds. But so it's a little different, but it's a similar idea. And that's kind of Mom 101. And you want to take advantage of that. Mom, how can you do a better job of exploiting is the wrong word, of using to benefit the healthcare delivery system? What would an effective role be? What role can you play to enhance healthcare utilization? And then other stuff can follow, but starting with that. Here's an example of what I call don't take no for an answer. Kid texts the therapist, "Can you stop calling my mother? I'm done. I don't want no more shots." And instead of taking the bait and getting into a battle, give us a call. Happy to come to your house. And then he said, "Thanks for sticking with us. We'll see you tomorrow for the shot. If you have any problems, you can let us know. We'll get you to the doctor." It's all about getting to yes. Here's a case scenario of some questions about how would you manage this family negotiation with a patient. So here's a 23-year-old female who's on one of the extended release injectable MOUDs, either extended release naltrexone Vivitrol or extended release buprenorphine Sublocade. But you're worried because they're late for the dose. Maybe they've started using again, or maybe you're concerned that they're going to start using. But the dose was due last Tuesday, and here it is Friday. And why did they miss their appointment? And maybe they have started some sporadic opioid use because the duration in the dosing cycle has expired and it's starting to have some breakthrough. So how do you involve the family? And I give some choices here, and I'd just be interested in hearing what everybody thinks. But one possibility is you say, "Listen, we're just going to call the parents and get them in, and because we can't wait around. It's an urgency. The kid could die tomorrow, and we need the parents to mobilize." Or do we hold off on that and see whether we can go one more round with the patient to get the dose, but not tell the parents? And of course, the kid is going to see it as ratting on them. So you're also thinking about protecting confidentiality and protecting the relationship and the engagement. Or would you say to the patient, maybe as a combination of those first two things, I want you to get the dose, and one of the leverage points that I'm going to exert is you need to get the dose or else we'll need to call the parents. And of course, I'd prefer to do it with you, but I'll do it with you or without you if you can't get the dose because I'm concerned about your safety. And remember, we said if we need to call the cavalry, we're going to do it. Or would you say, let's call your parents together so that I can help broker the communication and try to keep you out of trouble, but we got to get help for you because you haven't gotten the dose. Or would you say, I tell you what, let's call your parents, but I know you're reluctant and you don't want to get in trouble and you think they're going to cut your head off. So get the dose first, and then we'll call the parents, because then you can talk to them and confess from a position of strength. "Hey, Mom, Dad, I was a little late. I was at risk of relapsing. I was starting to have cravings." Maybe if you want to even confess, "I even used once, but I got back on the bicycle. I'm back on board. I want you to know I'm recommitted." And then you get parent points because you're being honest, but you're not ratting on yourself until you've course corrected? Or would you send a group text in a neutral way, just reminding everyone, hey, mom, hey, patient, the dose is past due. We're eager to see them. Bring them in, or we can come to see you and get the dose. And by the way, I don't know what's right here. I think you could make an argument for any one of these interventions, depending on the specifics of the case and the context. You know, how much of an emergency is it? What's your gauge of imminent risk? What's your past experience to predict the likelihood of any of these strategies working in a particular circumstance? But I lay them all out there just to illustrate that you got options. The menu has, and there's many more things perhaps you could think of, but there's a bunch of ways of proceeding, and all of them are with the goal of trying to make treatment progress and to use collaborative communication as a tool towards that end in one way or another. I'm going to skip these. This is just research results that we published showing that the yours intervention has some preliminary efficacy. I won't bother you with that. And I wanted to add that telehealth, you know, the lemonade of the last few years of the pandemic. Maybe some of you were telehealth experts before the pandemic. I certainly wasn't, and I've learned a lot. And I think it can add a great deal of nimbleness and reduction of barrier, and in many, many ways, as you probably know, and family engagement is certainly one of those. You know, so I have these examples here of ways in which you can use telehealth to facilitate family communication in a nimble and flexible way without potentially avoiding having to schedule people to travel through traffic. It helps reduce barriers, I think. So here's a 19-year-old young man in residential treatment, and he's had past problems with medication adherence. And so one thing you can do is have a video session with a parent to talk about a plan for medication initiation and adherence enhancement. Mom, Dad, what do you think about this? What are you going to do? Is it okay? And you know, not have to say, let's do it next Tuesday when you're off work. Can we figure out a way to have a 15-minute session conveniently by video? You got a 20-year-old that you're seeing by a telehealth session for sublingual buprenorphine as part of outpatient treatment, but she says that the parents are skeptical about buprenorphine. You know, many people have a peculiar idea about it. It's replacing one addiction for another. It's not real recovery. They'll just be addicted to the medicine. And you can just say, hey, is mom home? Is dad home? Go get it. Put them on the Zoom right now. Let's have a chat. You can do some psychoeducation. Let's talk to mom and dad spontaneously right now if they're available and willing about the pros and cons. And then this last example, a 24-year-old male with opioid use disorder in relapse, housing unstable. The family's having trouble getting him back into treatment. He's not at home. He wants to come home, but of course the family's understandably reluctant. You can't come to my house while you're using. We've got younger kids, your brothers and sisters here. You steal stuff. It's not safe. Well, let's have a three-way telehealth session from three different spots. You know, I'm in my office, the kids couch surfing at a friend's house, and the parents are at home. And let's talk about negotiating the terms of return home, but not today, contingent on certain treatment outcomes. That is, it's not no, it's yes, but. You can come home if, you can come home when. But here are the things you need to do. How can we facilitate your return to treatment? And you can be surprisingly effective doing that, even over Zoom. I mean, yeah, it's better eye to eye, perhaps in person, but that's harder to pull off. So just to conclude, I hope I've persuaded you that families can be a rich and robust source of recovery support. As I said, families will be around longer than we will, so use all the tools you can, and families are really a big part of your tool chest. It's not trivial. It requires flexibility. It requires a big lift, But the lift isn't as big as you think it is. It's easier than you think, and it's usually worth it. And I just want to encourage everybody that we need to work really hard to engage families, and it's almost always worth it. I just want to plug to conclude, I just want to plug two projects. One on the right, this is a University of Maryland sponsor endeavor. They have a state of Maryland grant to offer parent craft, which we talked about today, for an online training. So free online training that clinicians, that parents, that anybody can access to learn some of the parenting training tricks that we've been talking about. And they have nice videos and learn at your own pace kinds of instruction stuff. So check it out, or you can direct the families of your patients to check it out. And then on the left, a new program we've initiated to make individual therapist services available. We have a NIDA grant that allows us to do this without billing insurance or without charging folks, to do consultation and craft style family coaching for parents of adolescents and young adults who may have a problem but aren't yet willing to come into treatment, and to help coach parents with a craft style approach to help use their leverage and influence to eventually get their kids into treatment, but in the meantime, to learn some skills. So anyway, with that, we have some time for discussion, for questions. I'd love to hear what you think of all this. Maybe you've tried it. Maybe you've got some cases. So what does the chat say? Let me stop sharing.
Thanks so much, Dr. Fishman. That was a wonderful presentation. Yeah, if folks have any questions, comments, please feel free to enter those into the chat at this time.
And I suppose you could can we unmute people and they can talk? I don't know how many people we got.
I can see if
it may be unwieldy. I see there's 40 people or stuff. So let's start with the chat.
Okay.
Let me just see. Some introductions. Good afternoon. Yes, slides will be available. I've also got some references and resources on the last slide. You can go look them up, or you can email us and I can send you articles. And send you the two flyers one from us, one from the University of Maryland, if you want. Have you guys done some of this stuff? Have you ventured into family work? Or is it old hat? Is this what everybody's doing? Is it scary? What does everybody think? Here's someone who says it's very hard. I agree. Yeah, it's a big lift. But again, I want to make the point, it's not as hard as you might think. But I don't mean to trivialize it. It's work, and it takes time.
Dr. Fishman, I did get a question and a comment. This is helpful reframing. How do you see this intersecting with school staff and possible interventions, conversations, etc.?
So in the school, very tough. School-based health and behavioral health and SUD treatment is difficult. But on the other hand, as you know, it's got the advantage of that's where they are. That's where the kids are. So it's a huge engagement advantage. I think the principles are the same. Can you reach out to families and engage them in a way that encourages their participation while also simultaneously encouraging the emerging autonomy of the young person? And so I think it applies in schools. And if you can get input from teachers, sometimes they're pretty busy, and they will say things like, I can't even keep up with teaching reading, writing, and arithmetic. I don't have time for all this other stuff. So that's difficult too. But this is not new when you think about the treatment of ADHD and thinking about trying to mobilize teachers in terms of adding structure or monitoring medication effects, or getting school health programs and school nurses to help with adherence to medications. Those are all standard tricks of the trade that you guys know about. So I see this as falling in line with that.
Right. Another question, are there opportunities to train staff in some of the engagement strategies you discussed, such as guided role playing and what some common pitfalls are?
Yeah, that's a great idea. We are just starting to work on some of those materials. So I wish I could say, oh, yeah, here's my 7 manuals and have at it. I don't have that yet. We're working with a group in New York that's kind of better at media and training stuff than we are, but who's also very interested in family engagement and developing some of that stuff. And but I guess me and my staff are willing to do some of that training or to send some material. We have some materials, which I'm certainly willing to share. These slides, for example, might be a start. If you've got case examples that the staff know about, it's always a help to use real live examples that they're familiar with that are more concrete than just abstractions. I love the idea of role plays. That's a great idea. So I should add that to my to-do list to develop a bunch of guided role play exercises. And if you guys feel like writing them, that'd be great. I'd love to have those, and I think they'd be very good teaching tools. Who gets to play the sassy, ornery kid? That's the fun thing. That's the fun role.
Just a couple comments in the chat. Probably scary for most family medicine and peds in primary care, might need special training. School nurses and others can function in support roles.
Sure.
Finding that consistency is key.
And by the way, the point of how does this have legs in busy primary care practice is a very reasonable question. And I think you got to think about it as dimensional from kind of deep touch, like I can do in a low caseload grant-driven program, to brief interactions in a busy primary care practice. And at the other end of the spectrum, you won't have as much time. You won't be able to do as much training and as much negotiation. So it's a much lighter layering on. But think of it, if you will, in the same way that you might think of your asthmatic kids, your depressed kids that are not going to be good about medication adherence on their own. And what is it that you want you or the nurse or the clinic social worker to teach the family about a role for improving medical care utilization and medication adherence? And demystifying it, just because it's substance use, just because it's behavioral health, doesn't mean it has to be all spooky and scary and mysterious. I mean, yes, to some extent, but to the extent that you can demystify it and make it similar to other familiar puzzles in the delivery of healthcare to kids that have developmental vulnerability about utilizing care and being ambivalent about wanting to be in the patient role, it's the same idea. I know, easy for me to say, but yeah, but you get the point.
Sorry. Are there any suggestions you have for engaging a family when substance use is normalized and ingrained in family socialization and gatherings?
It's so tough, so tough. Here's a trick that I try to use. Sometimes it's helpful, sometimes they ignore me, and sometimes it backfires and makes them mad. But I use what I call my universal precautions approach, which is to say, hey, we're all concerned with little Johnny's use. And I just want to ask about use in the home. And don't get me wrong, I don't know you, and I'm not saying anything about you and what you do in your house. Plenty of people drink recreationally, smoke recreationally, whatever. I'm not implying or impugning. I'm only saying that if there happens to be use in the house, you know, kids are mimics. Kids will do what you do rather than do what you say. So listen, I know it's a lot to ask, and I know you're going to think I'm nuts. But when we're trying to change the behavior of a young person, it's probably better, if you can, and I know it's a lot to ask, to embark on a temporary, and it doesn't have to be forever, substance-free household status. So get the stuff out of the house. Don't do it in front of them. Maybe if you can stop temporarily. I'm not saying you have a problem. I'm only saying that we're focused on their behavior change and not normalizing it, because they can't tell the difference between what's normal, what's not. They can't tell the difference between what's appropriate and what's not. So 0 is the better exemplar. And as I say, sometimes they'll say, oh yeah, that makes sense. And then sometimes they'll punch me in the nose because I've offended them. Now, if they're actually interested, yes, action louder than words. Exactly right. No, I agree with that approach. Now, sometimes, if they happen to be amenable to your intervention and interpretation, and they want to be more disclosing, yeah, can you get them to treatment? Can you ask them about their use? But usually it's, I didn't come here for that. I came here for Johnny. You don't know me. You don't have any business telling me about me. Okay, fine. Didn't mean to insult you. It is a big problem in our culture, right? I mean, the families are so prone to this idea that I mean, what are the great myths? I'm gonna get them to learn. I'm gonna teach them to drink at home responsibly, and we all know that that's nonsense. That problem use status is directly linked to age of onset. And so postponing use as long as possible and no use at all is a better approach. That's hard for people to understand. Or we used when we were kids and we didn't die. No, that's right, but that's a low bar. How and just because you guys were lucky doesn't mean we can't improve things for the next generation. And besides, what was on the streets that you guys may have been smoking 40 years ago, it's a different drug out there. THC concentrations in plant cannabis that have been, cultivated through genetic crossbreeding are 8, 10, 15-fold more potent, and it's very scary stuff. It's not your grandfather's reefer. Again, though, the culture is not cooperating. And we're in the middle, as you know, of a big natural experiment that has made it medical, that has made it recreational, that has made it accessible. And I think it's going to go poorly for a subset of kids. I mean, most kids don't get into trouble, but enough do that I think we're going to see some very significant consequences over the next generation. Teens using cannabis daily. Well, the majority of the work is about motivational enhancement, because it's hard to teach skills for refusal when everybody says it's no big deal. Why are you bothering me? So the key is you're spending most of your time persuading the family and or the kid about impairment and trying to reflect to them in the narrative of their own life, not in some textbook. I mean, maybe the parents are interested in some of the textbook stuff, like, it's bad for school outcomes, it's bad for mental health outcomes, it's associated with increase in psychosis by 6 to 10-fold, blah, blah, blah. But kids aren't going to be particularly interested in that. But in the narrative of their own personal lives, as you get to know them, how is this contributing to your personal impairment? How is it contributing to your not being able to achieve your personal goals on the terms you want to achieve them? And connecting those dots, because they may say, well, I've got this trouble, I've got that trouble, I've got the other trouble, but that has nothing to do with smoking. Smoking's fine. What are you bothering me for? So how can I persuade you? How can I teach you over time that the dots may be linked, and that you ought to give it a try? And It doesn't mean forever. I'm not saying you have to never smoke or drink again. You could cut down. You could see what it's like. You could temporarily sample abstinence, but at least be open to connecting the dots and thinking about what it is you want to achieve, and could you achieve it more readily with less or none, none being the right amount. Sometimes I talk to young people about, well, all right, so you tell me that it's no big deal, you're not smoking too much, you can handle it, blah, blah, blah. Oh, my grades are fine. Oh, well, I failed that test, but that was because the teacher's stupid. It has nothing to do with my cannabis use. All right, well, that's fine. We can agree to disagree. I use that term a lot. We can agree to disagree, and that's fine. I appreciate your being honest to me, telling me what you really think. You don't think it's a problem. Well, how much would be too much? What would be a problem? And that exercise is to at least get on the same page in acknowledge, because they'll say, oh, well, I have a cousin or I have a friend or I know somebody. They smoke too much. Not me, but yeah, they crossed the line. They got in trouble. They failed. They got arrested. I don't know, their parents cut their head off, whatever it is. All right, good. So now at least we're on maybe we're not on the same page, but at least we're in the same book, that there could be such a thing as too much, that there is some threshold of impairment. And now the rest is details. So we can negotiate. All right, so fine. So let's think then about where your trajectory is headed. And here's an example. You say, as long as you're not smoking during school or before school, you only smoke after school and on the weekends, you think it's no big deal. Well, when they come back and see you next month, and it turns out, well, last week they did smoke before school, or they snuck out, at lunchtime. I thought you said, well, I've changed my mind. That's okay. All right, but at least now we're watching the progression in their own narrative of crossing a line that they said they wouldn't cross, and that they previously had labeled a threshold of impairment. And that allows you to give them some feedback in a longitudinal, dynamic way. And it's always going to be longitudinal and dynamic, right? It's not a sprint. It's not an epiphany. It's not a one and done. It's going to be the long haul of engaging with a person and seeing if you can help them. Anyway, we're over. I don't want to keep everybody from their busy days. So we should probably quit.
All right. Thank you so much, Dr. Fishman. Thank you, Max, for collaborating with us for this training. And just again, thank you everyone for joining us. Just as a reminder, please complete the evaluation link in order to receive your continuing education credits. And a full recording of this training, in addition to the slides and resources Dr. Fishman referenced, will be available on our website. That's www.mdbhip.org. That information's in the chat as well. So thank you again.
Oh, and by the way, a plug for BHIPP and Max, right? That if you guys have cases that are concerning and you want some consultation with, you can reach me through BHIPP and Max, and I'm happy to talk you through cases and talk about particulars. That's what we do. And if that's helpful, please feel free to reach out.
Sounds good. Have a good rest of the day, everyone.
So long.